Hi, I'm Holly Miller, and today I will guide you through a presentation discussing major depressive disorder in primary care. Major depressive disorder, or MDD, is one of the most frequently diagnosed mental health conditions in primary care. Nearly half of depression is managed by primary care providers rather than psychiatrists. Depression is characterized by persistent feelings of sadness or loss of interest in activities that interfere with daily functioning. It is also associated with worse outcomes in patients with chronic medical conditions, including diabetes, cardiovascular disease, and chronic pain. Because many individuals first seek care from a PCP rather than a mental health specialist, family nurse practitioners play a key role in screening, diagnosis, treatment, and ongoing management. Looking at the definition and pathophysiology of MDD, MDD is diagnosed using the DSM-5-TR criteria. A patient must experience 5 or more depressive symptoms during the same 2-week period, with at least one symptom being either depressed mood or loss of interest or pleasure. These symptoms must represent a change from the individual's usual functioning and significantly impair their daily life. The exact cause of depression is multifactorial and remains not totally understood. Evidence suggests that depression results from interactions among biological, psychological, and environmental factors. Alterations in the neurotransmitters serotonin, norepinephrine, and dopamine contribute to changes in mood, energy, and motivation. Chronic activation of the HPA axis may increase cortisol levels, while reduced neuroplasticity and lower levels of brain-derived neurotrophic factor may impair the brain's ability to adapt to stress. Genetic predisposition and life stressors further influence an individual's risk of developing depression. Individuals with a family history of depression or a previous depressive episode have an increased risk of recurrence. Women are diagnosed with depression more frequently than men. However, depression may be underreported in men. Conditions such as diabetes, cardiovascular disease, chronic pain, cancer, and neurological disorders are associated with a higher risk of depression. Lifestyle factors like substance misuse, poor sleep, and physical inactivity may also contribute to risk of depression. Psychosocial stressors, including bereavement, financial stress, unemployment, trauma, abuse, and social isolation, are associated with depression risk as well. Patients with MDD often present with persistent sadness or loss of interest in doing things that they once enjoyed. They might also complain of fatigue, difficulty sleeping, loss or gain of appetite, weight changes, difficulty concentrating, feelings of guilt, and when more severe, thoughts of death and suicidal ideation. When getting the patient's history, it's important to determine when symptoms started, if they've been present for 2 weeks or more, and if it has impacted their daily functioning. Some patients, like older adults, might only complain of physical symptoms like fatigue or chronic pain instead of reporting mood changes. There is no physical examination finding that in and of itself confirms the diagnosis of major depressive disorder. However, you can make important observations in the assessment. You should evaluate the appearance, speech, behavior, mood, affect, thought process and content, cognition, insight, and judgment. Patients with depression may have difficulty maintaining eye contact, show slowed speech, or have a flat affect. It's crucial to perform a suicide risk assessment, evaluating if the patient has suicidal thoughts, if they have intent, if they have a plan, and if they have access to weapons or other lethal means. If the patient is determined to be at imminent risk, the provider will need to refer the patient to emergency psychiatric care. Depression and other psychiatric and some medical conditions share many symptoms. Bipolar disorder is important to identify prior to initiating any sort of treatment because use of some antidepressants could precipitate mania in patients with bipolar disorder. The depressive swings in bipolar disorder or the low periods can often be confused for major depressive disorder. Generalized anxiety disorder often coexists with depression, but excessive worrying is a hallmark system of generalized anxiety disorder. Medical conditions such as hypothyroidism can also mimic depression through symptoms of weight gain, fatigue, and cognitive slowing. In this case, labs are recommended to exclude this from a potential cause of the patient's depression symptoms. Major depressive disorder is a clinical diagnosis and doesn't have a specific lab test. Diagnosis is based on a clinical interview using the DSM-5-TR diagnostic criteria, including symptom duration, severity, and impact on daily functioning. Lab testing is performed to identify medical conditions that may contribute to depressive symptoms, including thyroid disease, anemia, vitamin deficiencies, metabolic abnormalities, pregnancy, or substance abuse. In primary care, the PHQ-2 is commonly used as the initial screening tool for depression, followed by the PHQ-9 if the screening result is positive. The PHQ-9 is also helpful to monitor treatment response over time. Suicide risk should be assessed in every patient with depression or positive screening results using direct questioning and validated assessment tools such as the Columbia Suicide Severity Rating Scale. Managing MDD should be tailored to the individual patient based on patient preferences, their medical history, and their individual needs. Patients should understand that this is a treatable condition. Cognitive behavioral therapy is considered first-line treatment for patients with mild to moderate depression. Providing education about lifestyle changes should be provided, including the benefits of exercise, good sleep, socialization, nutrition. With safety being the number one priority, suicide risk should also be assessed at every visit so the provider can refer this patient to emergency services if needed. For moderate to severe depression, antidepressants are commonly recommended alongside psychotherapy. SSRIs are considered first line because of their safety profile, efficacy, and SNRIs are a good choice for patients with coexisting chronic pain. The treatment should be based on patient preferences, prior treatments and responses, their other medical conditions, and interactions with their other medications and possible side effects. It might also be a period of trial and error with different medications. Patient should be reassessed in a short time frame to determine if the patient is improving or if feelings of depression are worsening and if their safety is at risk. This follow-up should be within 2 to 4 weeks of starting treatment to evaluate symptom improvement, medication tolerability, adherence, and their suicide risk. Referral to psychiatry is indicated for patients with bipolar disorder, features of psychosis, treatment-resistant depression, or significant safety concerns. Thank you.